We discussed a number of problems yesterday. There are certain solutions, which is something that is very good. And yesterday we discussed how to apply the solutions in practice. Today, we will continue discussing efficacy and efficiency and how to address the objectives that we have. Before we resume the work within our forum, let me remind you the rules that we have. Honorable speakers, I kindly ask you to comply with the timing. I am sure you all have very interesting information in your presentations. At the same time, we have a number of speakers and we would like to fit in the agenda and have time for Q&A session. So I kindly ask you to be on time. I will take advantage of my right to intervention as a moderator. I may ask you to speed up if I see that your time is coming up. Dear participants, you can ask the questions in the chat and in the section Q&A. It is at the bottom of your screen in Zoom. We gather all the questions and ask the questions to the panelists. We will have parallel discussion today, which means that at about 11 o'clock, we will drop links to our chat with the link to the panel that you can choose. And you choose the panel that is more of your interest. Before we do that, we will repeat the instructions again. After the panels, we have these Q&A sessions that are moderated, and we have short breaks after each session. Let me remind you that we have simultaneous translation. You can choose Russian translation by selecting the language at the bottom of your screen. There is this little globe that you press, and you can choose the channel there. You can choose Russian channel or English channel. So it looks like we have introduced all the technical aspects, and now we move on to the speakers. Our first speaker today is Ms. Liat Ayalon, professor of the Bar-Ilan University in Israel. Ms. Liat Ayalon is an expert on ageism. She provides consultations to a number of state and non-governmental organizations on the issues of development and assessment of efficiency of programs for older adults. Being a Belarusian, I'm very curious to learn Israeli experience. Over to you, Ms. Liat Ayalon.
Did I get? Yeah. Okay. So I apologize that I will have to give this talk in English. It is good to be here today. And I will be talking about the impact of ageism on the mental health of older people during the pandemic. I would like to acknowledge the fact that this work was conducted and actually is already published with some collaborators, and you're very welcome to check out the paper that we published in the American Journal of Geriatric Psychiatry. It's online and it's free to access. So you're very welcome to read about that. Basically, ageism is defined as stereotypes, prejudice, and discrimination towards people because of their age. It is manifested in the way we think about people, the way we feel towards them, and the way we behave towards them simply because of their age. And ageism can be either positive, so that we, for instance, would do something nice to someone just because of his or her age, but it also can be negative. And it actually can be directed towards people of any age group, young and old. In this particular presentation, I will be talking about ageism towards older people, and I will be primarily discussing the negative aspects of ageism towards older people during the pandemic. And we know that actually ageism, the negative aspects of ageism, impact our health and mental health. And there is a variety of studies that have shown that having, for instance, negative perceptions of our own aging is likely to result in our reduced lifespan, poor physical functioning, poor ability to recover from a variety of surgeries and medical illnesses and so forth. We also know that ageism in the healthcare system has a financial cost, and there is even a number that we can put to assign to ageism and how it really impacts not only our health and well-being, but also the financial cost of the healthcare system. This is why ageism is actually very important. During the pandemic, I think that in addition to the pandemic, we have seen a pandemic of ageism. And older people have been portrayed as weak, as vulnerable, as a burden to society, as taking too much of the healthcare resources. And this has resulted in generations pitting against each other, especially during the early stages of the pandemic, when younger populations were thinking that this is really not their disease. This is because Corona was portrayed as impacting mainly older people and as being relevant mainly to older people. There are a couple of theoretical explanations to try to account for the spread of ageism, specifically during the pandemic. One of them is called competition over scarce resources, and the idea of that we all have, actually. It's a norm that we all have and have internalized that throughout our life, thinking that older people should not consume too much and should move away and give the right of the way to younger people. With this notion in mind, we have been operating during the pandemic, thinking that older people should not consume too much of the vent machines, for instance, should not be necessarily the first to get vaccines, and they should move to the back of the line and give the priority to younger people who are contributing to the economy and so forth. So this is one, I think, a theoretical explanation that accounts for the spread of ageism during the pandemic. Another one is called the terror management theory. And the idea behind it is that we all try to think of ourselves as immortal. However, when we meet older people, especially during the pandemic, when this association between old age and mortality has been stressed, we try to shed away and move away from older people who remind us of our own mortality. We experience death anxiety and try to move away, not to think about our own frailty and our own mortality. A third theory that I will be referring to throughout this presentation is called the stereotype embodiment theory. And the idea here is that we have internalized negative messages about old age throughout our life. And these negative messages become self-relevant in old age, and they really impact our aging process. And I will be talking about this more during this presentation. As I was saying, during the pandemic, we have seen a surge of ageism directed towards older people. And these studies have looked at how older people were referred to over Twitter. And one very common term used during the pandemic, especially during the first wave of the pandemic, was boomer remover, in reference to the baby boom generation that should move away again and give the right of the way to younger generations. There were statements about the fact that the life of older adults is less valuable, and that older people should be isolated and move away again so that the rest of society can continue its own business. These negative messages, actually, as I was saying, are being internalized by older people themselves. And in a study that we conducted that looked at how people over the age of 50 perceive old age, we've seen that many of them reported that older people are a burden to society, older people are a vulnerable group, and those who had these notions of older people as a burden and older people as vulnerable also were more likely to report higher death anxiety. They were more anxious about their own death, and that's why they perceived actually themselves as being a burden and being vulnerable. As I was saying, the problem with these messages is that they are being internalized and become self-relevant in old age. And there are numerous studies, even before the pandemic, that have shown that older people tend to think of themselves as slow, as a burden to society, as useless. And these negative messages actually color their aging process, so that when people think of themselves negatively, of their aging process in a negative way, they are more likely to age, they are more likely to die, they are less likely to recover from medical illness, and they are more likely to exhibit functional impairments. And this is why it is so important that we maintain non-ageist messages about older people throughout the life course, because these messages are being internalized and they affect the aging process of all of us, actually. There are various emotional consequences associated with the pandemic. And one such emotional consequence that I think is very important for us to stress is that during the pandemic, older people were afraid not only of the disease, but also of getting adequate medical care because of the notion that they are burdening the healthcare system. Older people were literally concerned about seeking healthcare services that they needed, because ageism actually has been so prominent, especially during the early stages of the pandemic. We have also seen a surge in social isolation and loneliness among older people, and many older people and vulnerable population also reported high levels of post-traumatic stress disorder associated with this exposure to the pandemic for a long period of time. We're not talking about an acute stress. We're already talking about a chronic stressor that has been affecting the life of older people and also young people, of course, for more than a year and a half now. I'm going to move now to long-term care settings. And these settings in particular, we have seen various behaviors that would not have been taken place in other settings. And I would associate these behaviors and these attitudes to ageism that is very common in our society. And we have seen worldwide residents being locked for months in long-term care settings in an effort to protect them physically. Yet this has compromised their mental health, and I will give you some examples of that in a few minutes. We have seen, again, in a variety of countries, stories about residents being abandoned, bodies of residents being hidden for days. And we have heard stories about limited workforce and limited personal protective equipment in a variety of long-term care settings. And these stories about limited workforce actually are not new to the pandemic, but during the pandemic, it has become evident that this is actually fatal and has major implications for the health and well-being of older people. I'm going to give an example here of one study that was conducted in a continuing care retirement community. And continuing care retirement communities are actually independent units that host older people who are independent upon their entering the setting, and they provide actually high levels of autonomy to the residents. Nonetheless, during the pandemic, residents were confined to their units for months in order to physically protect them. And we have interviewed these residents, and what they reported was a rupture between their life before the pandemic and life after the pandemic. Before the pandemic, they described their life as ideal. Yet after the pandemic, they really have noticed the major power imbalance between themselves and staff. And they try to use downward comparison to make their situation manageable. So they were saying to us that actually their situation in the setting, in the CCRC, is not that bad. And maybe other people, older people in the community are having a harder time even. Nonetheless, these residents also were very aware of power imbalance between themselves and staff during the pandemic. It was staff that knew everything about the pandemic, that knew who got sick, that knew what would be the next step, that also was able to make the decision whether or not the resident was allowed to leave his or her room. And residents have felt as if they have lost all the power during the pandemic. And these interviews were conducted during the first wave of the pandemic. This is where the measures that were taken to protect older people were the strongest. These measures had major effects on older people. And I'm going to bring here one quote of a woman who reported how her past traumas have really brought in new traumas associated with the pandemic. And this is a Holocaust survivor who was talking about her past traumas and how she re-experienced them during the pandemic. From that period, when I was 7 or 8 years old, all alone among strangers in a threatening world, I have learned how to block my feelings when I needed to. So that girl has become my counselor during lockdown. Even now, the girl is saying, I'm getting over this. I'm not thinking about this. I'm shutting this out. I reorganize things. So she's really going back and forth between different periods in her life to try to manage the situation. And residents were saying how they really felt like they have become prisoners of their own age. I think that it's very important to acknowledge the fact that especially during the pandemic, all the people who already had existing mental health conditions were likely to experience double or triple jeopardy. And there was a cumulative disadvantages associated with already having past traumas that have really exacerbated their experiences during the pandemic and made it very difficult for them to manage this new situation. We then moved to interviewing family members about the experience of their loved ones in long-term care settings. And older adults in long-term care were seen as declining functionally, having functional decline because all medical services, non-necessary medical services have stopped. And they also, family members reported an increase in symptoms of depression and anxiety among their loved ones in long-term care settings. Family members as well reported high levels of worry and guilt associated with having their loved ones in a long-term care setting. And also some of them reported a sense of relief associated with this solution. I'm going to read here two quotes that were provided to us by family members to give you an idea of what was going on during the early stages of the pandemic and how ageist decisions that try to protect older people actually hampered older people and also their family members. It was very difficult for my mother, very difficult. This isolation without being able to visit her and not letting her out. She couldn't quite understand it. She started saying it was Hitler who sent this virus. She started hallucinating and seeing things. So this caregiver is really talking about a substantial deterioration of her mother during the lockdown, during the early stages of the pandemic. And here is another quote, this time about herself. There is no end in sight. Do I know if she will live another year? I think the place is dealing with it just fine. At least that's how it was described to me over the phone. But of course, I don't really see what's happening inside there. If I could, I would pull her out of there, but I don't have the option. You know what? I really don't know what to think. I'm a bit confused by this whole thing. So family members felt very powerless during the pandemic because they had very few options to deal with the situation, and they couldn't really monitor the situation of their loved ones. If I conclude, I would say that CCRCs, continuing care retirement communities, were actually successful in physically protecting older people. However, it came at a price of compromising their well-being. And residents' defense mechanisms were successful to some extent. Nonetheless, as time went by, and actually the rest of the country, the community, went back to a new routine and things started to open up, yet these settings remained locked for months. Residents reported high levels of stress, anxiety, depression, despair, and anger. I think that we have found, based on the interviews that we conducted, that management and staff play a very important role in the well-being of residents and also of family members. And more flexibility and maintenance of physical and emotional routines are very important. And I can say that during the second, third, and fourth wave, the settings actually have remained open with the understanding that you cannot lock people for such a long period of time. And even if you manage to protect them physically, you do not protect them emotionally. Also, another message that was delivered by family members and by residents themselves was that the more transparent the measures that were taken were, the better were the residents and the family members. So transparency is very important and given a rationale for certain decisions. In terms of recommendations, I think that we have to shift, and we have shifted a little bit over the time. And from the early days when the pandemic was portrayed as affecting only older people, to nowadays when it's clear that it's affecting all of us. And we are all in this together. We also have to change the terminology. So initially, older people were described as vulnerable. We need to change the terminology and even use words like susceptibility. It's important to remember that ageism resulted in very paternalistic behaviors, especially during the early days of the pandemic, that hurt the emotional well-being of older people and also the people who care for them. Continued contact between older people and their family members is essential. And also older people and the outside world is essential. I also think that we should not throw away the baby with the water. So we should not necessarily abolish a long-term care setting because of what had happened during the pandemic. We have to remember, though, that every solution has its price. So if we want to protect the physical health of older people, it should not come at the price of compromising their well-being. I think that the UN Convention for the Rights of Older People is essential, and the pandemic has demonstrated that, because I think that we need guidance as nations and as people as to what is considered a violation of human rights and what is considered okay to do in order to protect people. I also want to note that there have been multiple incidents of intergenerational solidarity between old and young people, and we must acknowledge that. I'm going to conclude here with the recent WHO campaign, which has started actually in 2016. And I was very optimistic when they started with the campaign, thinking that they will create a societal change, a word for all ages, by changing the way we think, feel, and act towards people because of their age. During the pandemic, I have lost my optimism and have become quite despair. But now I'm thinking that maybe the pandemic was actually has brought the topic of ageism to the spotlight. And maybe now we have the opportunity to make a societal change and really create a word for all ages, where people are not discriminated based on their chronological age, are not receiving different treatments, different rights, simply because of their chronological age. And we don't think or feel towards older people in a different way or act in a paternalistic way simply because of their age. Thank you very much for your attention.
Dr. Liat Ayalon, очень признательным.
Dr. Liat Ayalon, thank you very much for your interesting presentation and this interesting topic, and I'm looking forward to the Q&A session to uh, provide my feedback on that. For now, I give the floor to Dr. Marion Staunton, who is representing international organization Health Age, a big network. She unites organizations around the globe and works with people of older uh, adults and provides help to older adults. And it ensures international approaches. Taisiya Sergeeva is a major partner in Moldova. Her expert experience might be very close to our region for Belarus, including for Belarus. Over to you.
Thank you very much. Good morning, everybody.
Marion,
Sorry, Marion.
I'm so sorry, just a little technical issue. Татьяна, пожалуйста, примите приглашение в панелисты, мы вам отправляем, иначе вы не сможете выступить и не сможете совместно с Марион что-то сказать. У вас в Zoom выходит...
Tatiana, you need to accept the invite to become a panelist.
I could proceed, perhaps, if that is okay, because
Yes,
I'll be making the presentation. Is that okay?
Yeah, please do. By all means, proceed.
Thank you very much. And I would like to thank the previous speaker who has touched on very important issues in relation to ageism. My name is Marion. I work with HelpAge International in their humanitarian team as their protection and mental health psychosocial advisor. This morning, I would like to share with you some of the good practices and activities that my colleagues in Moldova and Ukraine have recently been implementing with older people in relation to the impact of COVID. But let me first share with you briefly some information about HelpAge International and who we are. HelpAge International is a worldwide network of organizations standing up for representing the rights of older people. We have 158 members, partners, and country offices across 86 countries, including Moldova and Ukraine. Our shared goal is creating a fairer world for older people so they can live safely, healthily, and dignified lives. We seek to improve older people's lives by helping them to overcome poverty, increasing access to health and care, also advocating for better pensions. That is within the development context of our work, but we also work in humanitarian settings, working with other organizations to ensure that older people's needs are met. As we know, and as our previous presenter has outlined clearly, COVID-19 has had a tremendous impact on everyone's lives, but in particular older people. HelpAge International have published a number of reports on its impact, and indeed one report was conducted with support by UNFPA called Bearing the Brunt. And these reports are available on our website. But in summary, older people have been shown to be at a higher risk of serious illness and their survival rates are lowest. Many older people throughout the world have lost their livelihoods and cannot even afford to buy food or medicine in order to survive. And as we have seen from the previous presenter, the pandemic has exposed ageism in quite an alarming way. Older people have been separated and isolated. They have been portrayed as weak and helpless, and their rights have been ignored. They've also been presented as a very that all older people are the same, which is not actually the case. And this has all had a huge impact on their health and well-being, with older people now facing more violence, abuse, and neglect than before the pandemic. What I would like to share with you now is some of the activities that my colleagues have implemented in Moldova and Ukraine in order to combat some of this impact from COVID-19. So one of the first activities or projects I'd like to share with you is one that aimed to link older people with younger people in relation to using mobile phones and connecting to the internet. But just some facts first on Moldova. As we know, older people are among the most impoverished there, many without access to decent, reliable incomes, living in homes without running water. Without the internet and mobile phones, older people are often isolated, not feeling connected with others, and this is particularly in the case in rural areas. Interestingly, Moldova ranks third in the world on internet access speed. However, only 3% of older people there use information technologies compared to 41% in EU countries. They have the lowest access to mobile communication of all the demographic groups, and only 2.9% of older people can use computers compared to over 40% average for the UN countries. So this project, which was called, Hack Your Age. The goals of this project was about creating digital and social connections between older and younger people in Moldova across 10 communities. In 2021, the continued aim of the project is empowering and building social resistance of older people in a number of communities. And this was being done by fostering, encouraging that intergenerational dialogue or connection between young people and older people, but also having a practical result in improving older people's access to quality social services and also reducing their isolation. Now I'm just going to share some of the activities and results from the project for this year. 200 mobile phones were donated to older people. There were a number of training of trainer sessions for younger volunteers on how to use the mobile phone and social networks and how to share this with older people. This was all done online. We also had training sessions by HelpAge colleagues for younger volunteers on what it means to volunteer, what we mean by active aging, and also principles around safeguarding, protecting themselves and older people. Now for the rest of the project, 50 young volunteers, they conducted training sessions that covered information like sending text messages, using the different communication apps like Facebook, WhatsApp, and refilling credit. They also, older people with mobility difficulties or disabilities, they in turn were trained by these young volunteers at home. And in addition to this, given the context we are in, older people received PPE and food packages that were again delivered safely at home by young volunteers. Now, I just want to share with you some of the responses from older people who were part of this project. So one woman was saying that thanks to this phone, I am now in the know about the news in Moldova and in the village because I'm a member of the Viber group. Young volunteers have taught me how to use the telephone and how to use these different applications. Another person said, I felt as if I'm in the first form again. And one that I found very interesting was the comment, now I understand why young people spend so much time on the phone. I have discovered YouTube and I am looking up songs from my youth. That's just some of the responses from some of our older people using the phone. So not only did it help with building connections with younger people, reconnecting with their community, but it also was a way to share important information for older people. Planned activities for this year is that 250 older people will be again provided with practical training on using the phones, accessing the internet, but also looking at ways to access, public services, manage their bank accounts. There is also group psychological sessions to older people to overcome isolation and challenges that have been caused by the pandemic. These focus on coping techniques, how to manage stress, and also look to tap into the resilience and strengths that many older people do have. It's enabling older people to use social media to share their experience about growing older, aging in Moldova, and also how to take pictures, how to upload videos and weekly posts on social network sites. Finally, there are plans to have a conference on digitalization and aging with participants of over 200 older people connecting online to this meeting. The next set of slides that I have will be sharing with you some of the activities from HelpAge Ukraine, and the first one is around community safe spaces. Community safe spaces, they were spaces where older people, including many with disabilities, can gather safely, particularly in relation to these times with COVID. And these spaces were a place where older people and other members of the community could meet and socialize with each other. Different group activities and opportunities for older people to meet up, to help reduce feelings of loneliness and isolation. And it was also importantly about rebuilding community networks and friendships, and to promote intergenerational activities to challenge discrimination. Some of the examples of these activities that have been run in the community safe spaces have included knitting, gardeners clubs. You can see our gentlemen playing chess, also fitness classes, and also community spaces were a place where information, accessible information, could be shared with older people on many different important issues, because that has been a challenge and sometimes overlooked about how can we share information with older people in a way that all of them can understand, can ask questions and take it in. One of the most active groups that has emerged from these community safe spaces were our peer-to-peer support groups. As I mentioned before, one of the important things we need to realize and acknowledge is that many older people have incredible strengths and resilience and have experienced a lot. They are not all the same. So with our peer-to-peer support groups, we have older people who can become what we know as peer champions. They are trained and guided by HelpAge staff on how to provide peer support. They're trained on topics in relation to gender and disability awareness, how to take care of ourselves, how to take care of others. And within this particular activity in the Ukraine, peer champions, they started to do home visits with trained community volunteers to isolated and lonely older men and women who, for different reasons, could not attend the safe spaces. One of the other activities within Ukraine that has had tremendous success and impact on older people's lives is what we call home-based care. And these are home visits by trained community volunteers to older people who are isolated or immobile. I'm almost finished. And these community volunteers are themselves older people. So just in summary, they supported the older person with many different activities, whether practically about housework and also simple exercises to improve their independence, but also, more importantly, befriending, sharing information with the older person and connecting them with their neighbors and their community again, with the focus of reducing their isolation and loneliness. That, in summary, is some of the really good work done by my colleagues in HelpAge Moldova and HelpAge Ukraine. We are happy to share with you any information that you would like about these activities after this session. And I would like to thank UNFPA Belarus for this opportunity to share this information with you. Thank you.
Благодарю. Marion Staunton.
Thank you, Marion Staunton. What about your second speaker? Is she going to speak? I mean, Ms. Taisiya Sergeeva?
No, thank you very much. Tatiana will be available for any questions that may come up later on, but that's our presentation. Thank you.
Я понял, благодарю вас.
I see, thank you. In this case, I guess we can start our Q&A session. Do we have any questions posted in chat? I'm referring to the technical team. I see a question from Sofia Abramova. What is safe space during pandemic? How can you create such a place?
I'm happy to make an attempt to answer that question. With our community safe spaces existed before COVID-19, and with the onset of COVID-19, of course, that activity had to reduce. But when it did resume, what my colleagues did in Ukraine was to take into consideration public health messaging and guidelines on how to have such an activity that would keep people safe. So, for example, there was a less number of people allowed to be in that one space. It was ventilated, and I think you may have seen on some of the photos on my presentation, people who were attending that activity were wearing face masks. So that is what I mean by safe space in relation to recognizing the situation of COVID-19. In another context, safe space was about where older people could come together, engage with each other, socialize in an environment where they felt safe and accepted. I hope that answered your question.
Хотите что-то на эту тему добавить? Если нет, можем перейти к
Liat, would you like to add something? Or, well, if not, I'll have a few questions of my own. My question is to Liat, if I may. Is my understanding correct? One of the key facets of the problem is language barrier. I mean, how do you communicate this or that condition related to the pandemic, and in what form this information is delivered to the elderly? You provided examples with, and you focus that we need to speak about susceptibility. So do I understand correctly that this is a matter of communication and not practicality? Because older people are more exposed to risks during the pandemic.
So I wanted to apologize because only now I noticed that I could have received translation.
Okay.
Sorry.
I actually asked it in Russian, so just to save us some time, I could do it in English just one more time.
I missed the translation, Keith. Sorry.
Yeah, okay,
I just
okay,
now saw
okay.
that.
Just a second. Коллеги, я сейчас по-английски просто повторю то же самое, что спросил по-русски. Liat, you mentioned, is it my false understanding, or is it that you actually see the problem mostly in a communicative way, like it's more of a language problem? It's not like policy problem or actions problem, but mostly like communication between age groups. So the older age groups are receiving information in some, let's put it like that, like in bad way, yeah, but it is actually not, the policies are okay. We only need to change communication. Am I right with that?
Actually, I think, as I said, ageism is both the communication, the way we speak or the way we think, the way we feel, and the way we act. And I think that this is the situation also during the pandemic. So certainly we have seen in the media a lot of discourse that portrays older people as vulnerable, as a burden to society, and also allows actually for acts, for measures, for policy measures to take place, even though these were quite discriminatory policy measures, such as, and I haven't actually discussed many of these measures, I just referred to the ones that were taken in long-term care settings. But we have seen actually in a variety of countries around the world, at least at some periods during the pandemic, we have seen measures, policy measures that were ageist, that were discriminatory, and said that older people can stay in lockdown and the rest of society can go back to life. So I think that it's not only the communication, it's also the policy measures that were taken, and obviously also the interpersonal occurrences that took place privately. So I think that it's actually a lot more than just communication, but communication allowed for discriminatory policy measures to be acceptable.
Can I switch to Russian now? Okay, yeah. Я еще дополнительный.
Well, additionally, I would like to ask one more question. My company and myself, we conducted research on ageism in Belarus for UNFPA in 2019, and there we identified one of the findings was that major factor to differ ageist people and non-ageist people is the perception of older adults as socially non-valuable. So this is neglect of their value for their society. So right now I am thinking that those policies that would communicate the need to protect older adults, for example, with the help of CCRC that you mentioned, this looks like a good counter activity to fight this phenomena of neglecting the value. To what extent this idea is in line with your vision of what is the right way to communicate with older groups of population within the context of COVID-19? I hope I made my question clear.
Yes, it's clear. Thank you for the translation. So actually, I am thinking that these measures that were taken in order to protect older people many times did not really try to protect older people. I don't think that the measures really had in mind that older people represent a valuable group. I think they try to protect healthcare systems that have been starved to death for years all over the world, actually. And I think that the measures that were taken were really aiming towards protecting the healthcare systems rather than protecting older people. And I think that many times the idea of protecting older people and isolating them while the rest of society goes back to semi-normal actually represent another devaluation of older people, thinking that they are not needed for society. They're not needed for the ongoing social operation of society. So I see this also as ageism and as another way not to acknowledge actually the value and importance of older people as an integral fabric of our society, basically.
Благодарю вас.
Thank you very much. I have a question for Marion Staunton. Based on the vast experience that Help Age has, what are the practices of work with communities of older age people you would recommend for all communities working with the people people of older age, for example, 65 years old and over? Are there any mistakes in such work? Could you highlight what should be avoided?
Thank you for that question. I will do my best to answer it. From a humanitarian perspective, which is where I work, the biggest mistake or oversight by different organizations is not collecting disaggregated data on older people. And what I mean by that is, if you want to understand the needs, if you want to understand how you can work with and support people and older people, then you need to know what they are. So what I mean by that is, in needs assessments, you don't you break it up into different age cohorts, right? So you don't go 65 plus. You break it up into 65 to 70 and so on, because as I said before, older people are not all the same. And as our previous speaker said, older people are not all vulnerable. Again, that's language. We really should be using things like most at risk. So that is a big oversight in relation to humanitarian work, in relation to responding to emergencies, is that in our needs assessment, not everyone, not all organizations are collecting data and information that's broken down, disaggregated based on sex, age, and disability. The second thing is including the voice and participation of older people in how they want to overcome the situation they're in. And that includes COVID, engaging with, asking, discussing, open up in the dialogue with older people instead of coming with this kind of top-down approach on this is what we're going to do to protect you. That is the other thing I would say. And also, again, within humanitarian work, what we have found, even in the examples from Moldova and Ukraine, older people can be part of the support that you are doing. That peer-to-peer work that we did in Ukraine, we also used that kind of activity and model in Venezuela. And we had a partner organization train with over 100 older people who were interested, who wanted to support others on how to use mobile phones. And they in turn built peer relationships with other older people that really had a huge impact on their lives. That project is finished, but those peer supporters continue to do what they're doing. So I hope that answered your question.
Благодарю вас. И последний
Thank you
вопрос.
very much. And the last question, a question to Liat Ayalon from Olga Atroshenko. According to your opinion, what are the most effective to reduce internal stigma in people of older age? What are the structures that can play an important role in this process?
I think this is a really good question. Actually, as part of the WHO campaign, they conducted a systematic review to identify the best ways to combat ageism. And the 3 tools that they identified were education about ageism. Another one was intergenerational contact. And the third tool was legal interventions to prohibit ageism. I have to say that all 3 methods do not directly talk about self-ageism. And actually, many of the studies look more at other-directed ageism rather than self-directed ageism, how we think of our own aging. I would say, based on the literature, that certainly communication, media messages, and so forth do feed into our self-image. So we do need to be quite aware of the messages that we receive from society and ensure that all the people are portrayed in a very diverse way. So we don't want to portray older people only as successful agers, but also not only as older people with disability. As Marion was saying, we want to show a heterogeneous experience associated with old age and aging. And this is one way to combat ageism, so that people will understand that older people is not a homogeneous group, and there is diversity associated with that.
Благодарю Liat Ayalon, благодарю.
Thank you very much, Liat Ayalon. Thank you very much, Marion Staunton, for your interesting presentations. It was very curious for us to learn this information. And let me close this session, the first session for today. And we will have a short break. After the break, we will start working in parallel sections. The engagement of communities section is going to stay here. You don't need to leave if you want to attend this section. If you want to attend this section communication, you need to follow the link that will be sent right now by my colleagues to the chat. I will leave you as a moderator of these sessions for the parallel session in communication. The community engagement will be moderated by Alona Stanislavchik, who represents the Belarusian Association of Social Workers. She has vast experience in providing services to older age persons, and this communication section will be moderated by Sergei Kruchinin, who is a lead expert of the working group in UNFPA to develop information strategy to communicate with older population groups. So no worries, dear participants and panelists, you are in good hands. We have a 10-minute break. See you at 10:11, meaning 10 past 11, according
Добрый день, уважаемые участники. Меня зовут Алена Stanislavchik.
Good day, dear participants. My name is Alena Stanislavchik. I will moderate this session on best practices on community engagement, providing support to older persons. Before we start, I would like to highlight a few technical issues who just joined us. I would like to clarify that there is a parallel section going on right now, the parallel session on communication. In order to attend it, please follow the link in chat. For those participants who stay with us, I would like to remind that you can ask questions using the Q&A button or the chat. We would like to discuss all the questions at the end of the session. I also have a kind request to our speakers about the time frame for your presentation. So we are starting our work. It is not just by case that we have community engagement allocated in a separate session. The friends and the immediate environment and in general members of the community where the old persons live. This is mentioned in international documents as a resource for development and implementation of programs for the benefit of older persons, and this resource is a fundamental tool, especially when we talk about emergency situations like COVID-19. At the beginning of our panel discussion, we will familiarize with the experience of those organizations that, in my eyes, do not need any specific introduction because they are widely represented around the globe. They have vast experience in providing support to people around the globe. This is the International Federation of Red Cross and Red Crescent. Let me pass on the floor to Aneta Trgachevska, who is coordinating the healthcare projects targeted at older persons in the regional office for Europe. Over to you, Aneta.
Thank you very much. Good morning, good afternoon to all of you. Just a moment. Can you see my presentation?
Yes, we can see your presentation.
Okay, great. Thank you very much. Thank you very much also for inviting me and for giving us this opportunity to present and to provide general overview of the activities that Red Cross and Red Crescent National Society in Europe and Central Asia are implementing to support older people, particularly in the ongoing COVID-19 pandemic. The health and aging is the main priority of the IFRC Regional Office for Europe. This comes from the Vienna commitment in 2010 when the European Red Cross and Red Crescent Conference recognized the special challenges the aging population presents to national society. Later in 2012, commitments were reaffirmed, aligning the Red Cross and Red Crescent action with active aging and solidarity between generations. Our priorities and commitments are also complemented with the IFRC Strategy 2030, IFRC Health and Care Framework 2030, and also Global Strategy and Action Plan for Health and Aging, the 2030 Agenda for Sustainable Development, and now Decade for Health and Aging 2021-2030. During the COVID-19 pandemic, Red Cross and Red Crescent National Society actively contributed to development of health and aging strategy, framework, and key priorities for action to 2030. Using life course approach, we have identified 4 key strategic pillars. The first one, ensuring the physical, mental health, and psychosocial well-being of older people, addressing ageism and age-based discrimination and exclusion, promoting intergenerational solidarity and dialogue, and positioning IFRC and national societies as leaders and advocates. Just to mention that on regional level, we have established a health and aging regional advisory group in 2019. We have 29 national societies that are members in this advisory group. with the main mission to strengthen the capacities of the national societies in working with older people as a result of sharing and dissemination of quality standards and evidence-based programming. Just to mention that our IFRC regional office is covering 54 national societies, and out of these 54 national societies, more than 39 national societies were implementing different kinds of activities to support older people before COVID-19 pandemic. During this pandemic, Health and Aging Advisory Group actively functioning and supported technically and programmatically national societies who are implementing different kinds of programs for supporting older people. They were providing regular updates and advices on available tools, publication, capacity building opportunity, integration of health and aging in other non-aging activities like disaster preparedness and risk reduction, health in emergency. We also conducted some evidence-based research and studies that aim to obtain evidence-based data on the current needs and the most vulnerable group of communities. On this slide, you can see the various activities that were implemented by the Red Cross and Red Crescent National Society in Europe region. You can see that 36 national societies are implementing different kinds of activities to support vulnerable group of population, including older people, and 39 national societies are implementing mental health and psychosocial support services, not just for older people, but also for other vulnerable groups of population during the COVID-19 pandemic. During the whole year, the national society were supported with different technical guidelines that were produced at global and regional level. So the technical guidance documents provided key messages and activities to be included in the national society response, aiming at addressing needs of the most at risk of exclusion and isolation. Also, some technical webinars were organized together with the UNFPA, with WHO regional office, also between the national societies to discuss their activities and challenges related to addressing risks and vulnerabilities and to provide guidance on best ways to adapt services and address access barriers. You can see some of the publications that we have produced, and all these publications are available on our website. So I warmly encourage you to visit our website, and I will also share the link after my presentation. We also have developed some online training courses in order to build the capacity of the national society to better implement their activities. They are also available on the IFRC learning platform, which link I will share after my presentation. Just to mention here the publications and the online training courses are available on different languages, including Russian language. National societies since the beginning of the pandemic have been implementing different community-based activities, and they showed and they had a significant role in outbreak control to contain, slow, or suppress transmission of the virus, while ensuring that people affected can meet their basic needs, essential services, and maintain their dignity. National societies are reaching vulnerable group of population, including older people, older persons with chronic diseases, with activities such as distribution of food and hygiene parcels, procurement of medicines, providing them with hot meals, shopping services, providing assistance with farm animals or home pets care, paying their bills, helping them with small housework like cleaning, washing, cooking, and also check-ins on those who are known to be isolated and living alone. Some of this is worth to mention that some of the older people reported that their family members lost jobs and were no longer able to support them. So in framework of our capabilities, Red Cross and Red Crescent National Society have provided also cash voucher assistance to this group of older people. Regarding the mental health and PSS support for older people, as I mentioned, more than 38 national society established or participated in implementation of mental health and PSS support for older people. So they established and were running telephone informational lines in order to address the rising causes of stress, loneliness, insecurity, and fear caused by pandemic through actively listening, emotional support to people, and helping them to deal with challenges. At first, these hotlines offered the callers general information about COVID-19, but then they provided various services like information sharing on different topics and services available, answering different questions of the older people, collecting feedback from them, making referrals, telemedicine, social care, and linking older persons with the needs to volunteer and services. They were also providing individual and group sessions, online psychoeducation, online consultation. They have organized poetry competition for older people in order to express their emotions and cope to this, with stress. Also educated them how to use digital technology. Some of the national society provided also tablets or mobile phones to older people in framework of their capacity and capabilities. I would mention also that some of the national societies are implementing activities to support older people with Alzheimer and dementia. So they have developed training programs, mostly for capacity building for caregivers, which is composed of 5 modules, like cognitive abilities, movement, perception, everyday activities, games, and creativity. Some of Red Crescent National Society were actively involved in screening or awareness-raising activities about Alzheimer, dementia, prevention. French Red Cross, for example, have established non-medical reception centers that complement specialized medical institutions and offer activities that are adapted to the conditions of those living with Alzheimer, and allowing the caregivers or relatives or family members to set aside time for themselves and to address their own needs. Activities in these centers are centered on sharing thoughts, listening, maintaining social relationship. The people with Alzheimer and dementia can participate in group activities such as board or card games, dancing, playing some instrument, etc. Health and aging and promotion of healthy lifestyles and prevention of non-communicable diseases are implemented by majority of the national society. The overall goal is to contribute to healthier life and healthier aging of all generation. And we as IFRC call for a life course approach, emphasizing that the healthy lifestyle should be at every stage of the life. So you can see from the pictures, we are starting with the kids from the kindergartens and continuing at older ages. The activities that the national societies are implementing are based on the healthy lifestyle toolkit and model that was developed together with the Pfizer, and it's also available on our web page. It's very practical toolkit to increase the knowledge and equip communities with tools to make healthier lifestyle choices. And we want to tackle underlying social, behavioral, and environmental factors that determine good health and bringing about the required changes in behavior and attitudes that reduce the risk of non-communicable diseases. Regarding the evidence-based data, I would like to mention the impact study of the COVID-19 on older people and caregivers that was conducted in South Caucasus countries from July to September 2020. IFRC in close partnership with Austrian, Swiss Red Cross and national societies of Armenia, Azerbaijan, Georgia, and of course with collaboration with UNFPA offices in Armenia and Georgia, conducted this study that aimed to understand the impact of COVID-19 on older people and caregivers, and also on Red Cross and Red Crescent volunteers. The study looked on one hand at national frameworks, policies, and strategies related to the care of older people and their implementation, while on other hand, it analyzed the perception and experience of older people and professional caregivers and trained Red Cross and Red Crescent volunteers before and after COVID-19 outbreak. Just to mention that in analyzing the situation of older people, the study focused on their economic well-being, health, social care, access to public services, home-based care, residential care, and civil activism. I will just highlight some findings that, for example, the negative impact that was reported regarding the mental health and spiritual well-being, physical activity, nutrition, and diet of older people. Also, access to health services was mostly difficult for those not receiving home-based care services. Also, 30 to 40% of the responders have reported that have some chronic diseases. Social contacts were also decreased with neighbors, with community, and with family. And what was interesting that 1/3 of the older people had experienced some kind of violence, but many of them don't have access to legal services, or they didn't report this violence. I will also provide the link of the report so you can also get a comprehensive picture about this finding. And last, I would like to mention some activities that are conducted by more than 32 national societies nowadays with support for COVID-19 vaccine rollout. So the Red Cross, Red Crescent national societies are focused on provision of transportation for older people to vaccination points, assistance with the registration process, offering psychological first aid, monitoring on possible adverse reaction after receiving the vaccine. Also, they have established mobile teams in collaboration with the local health facilities to reach older people in rural areas and to ensure that every older people will have a chance to be vaccinated. I will conclude here with that the ongoing pandemic once more again underlined the need to invest in community-based health. And it's clear that we still need to do much as a society to better understand how the services have to evolve in order to fully integrate the choices, needs, and challenges of older people. And older people as active agents in these changes should be and need to be kept at the center of our future activities. We need to listen their voices, suggestions, and ideas to build more inclusive and age-friendly societies. I would like to thank you for your attention, and I'm really looking forward to work together with all of you. Thank you very much.
Огромное спасибо, Анета, за
Thank you
очень...
very much, Aneta, for the interesting presentation and your practical experience that you have shared. Thank you very much for mentioning the tools, and I am sure that for the practitioners it would be very useful to look into the study you have mentioned and to use the toolkits you have mentioned. And I'm sure our practitioners will familiarize with those documents. And it's wonderful that they are translated into Russian. We can get to know those.
Yes, I will
This
provide now the
information.
link. Yeah, thank you.
Да, я сейчас хотела бы предоставить
Yes,
слово моей
thank you. Now I would like to pass on the floor to my colleague from Belarus, who represents an organization who has numerous years of experience in providing services to people with cognitive disorders and Alzheimer's disease. This is a public charitable Jewish organization. He said, Rahamim. I would like to pass on the floor to Ekaterina Sergeeva, specialist on mental health and coordinator of the programs on and also on creating favorable environment for older persons. Over to you. Thank you very much. Good day. The topic I would like to introduce is engagement of relatives and community in caring for and accompanying people with cognitive impairments. To describe it very briefly, the first slides will be describing the experience of our organization, what we do, what we used to do before COVID-19, very briefly, and what are the challenges we came across during COVID, before COVID, and during COVID, what we did in the organization for people with cognitive impairments, and with the people who we used to work with before COVID and continue working. And I will demonstrate a few examples, and these are quite valuable for us. So organization has been working for a number of years, and we have been providing services to pensioners, people with disabilities, and families in crisis situation. We implemented case management approach, and for the first time, we tried to implement this pilot project in 2015, and starting from 2016, we started comprehensive work with people with cognitive impairments. If we try to describe all the experience of our organization, we can split it into 3 dimensions. First is providing home-based care for older persons, providing financial support in purchasing food, medications, and supporting crisis situation, and resocialization and adaptation of older persons and people with disabilities. And during the pandemic, we faced unusual situation. It was no longer possible to work the way we used to. So home-based care is personal hygiene, cleaning, cooking food and feeding, and we had it all well elaborated. And this work was ongoing from the very beginning of the existence of the organization. And as of today, this is a huge amount of work that we never stopped doing. So the key programs that we have, talking about financial support, this is quite a big component that we have. There are certain criteria. And if we try to split this, we have a club for older persons. This is aimed at overcoming loneliness and the social resocialization that I mentioned when people have cognitive impairment and different types of disability. We have different directions of work. Talking about the work with people with cognitive impairments, in 2016, we launched the project and created 2 groups. This is like a daycare center. We trained our staff. We actively trained volunteers, and we started to work and provide home-based care. This was about 16 people at that time. Of course, this number was fluctuating. And these were daycare activities, work with volunteers, coordinating work, and awareness raising for general public. As for March 2020, when we started to do remote work and combined format. We established 4 groups in Minsk, 2 in Bobruisk. We were conducting home-based visits. We conducted internships for representatives of state organizations. We conducted 4 conferences. By that time, we made a collection of materials in cooperation with the Ministry of Labor and Social Protection for specialists with the support of the program. Our trainers and experts drafted books and guidelines for relatives and caregivers. We made 12 videos on working with the clients, and we participated in the national research conducted by the Ministry of Labor and Social Protection. At that time already we faced certain challenges. There were challenges in diagnostics, especially during the early stages. It is always difficult to work in person during COVID, and we were looking for ways how to do this at early stages, and we found out that there is low level of awareness among specialists and relatives of clients. We identified that there are certain discrepancies at the local level and at the level of legislation framework. There was no social support, accompanied social support, and when we were doing certain translation, there was this discrepancy in the terms care and support, which is like maintenance support. And here there is certain discrepancy in translation as well, and it is still there. It is a matter of terms. There was a time when we were working not online, we were doing home visits. There were certain issues with delivery of grocery and etc. But the major issue for us was how to engage relatives, how to ensure this cooperation, because we did a lot of activities. We communicated with the family and the environment in different ways. However, unfortunately, our groups and the way we saw it, they were not enrolling enough participants, they were not coming to the meetings, and this was a pain for us. So if we say that these are children, they work also in the evening, and sometimes it's difficult for them to leave their person whom they are providing caregiving services. And if this was a wife or a husband, the question was how to leave this relative back home and attend the meeting. And we were looking into ways how to address this, and home-based visits were working out well. Psychological support worked out well, and we looked for different ways to ensure counseling, legal counseling, medical counseling, and we came to the homes of people to explain what has to be done in order to improve the safety in the apartment, what could be done to improve the general conditions. The family members said that they have that they are shy, that they have a certain feeling of guilt, and this impacted the condition of the family, and many people had lower income. And I received a call recently, a young girl who has a child, and the doctors confirmed the diagnosis of dementia for her mother. And she says, well, it's very good that I have the father who can take care of the mother, but he cannot work because he has to take care of the mother, of his spouse. So we can see that the workload increased for these people. At the same time, we noticed low level of awareness among family members. So what happened when COVID came? Of course, we had to revise budget on all budget accounts because all the regular meetings with a cup of tea and all the group and teamwork had to be readjusted in a very prompt way. We procured a lot of personal protection equipment for patronage workers. By saying patronage workers, I mean social workers. We had hotline. We provided awareness raising campaigns, including workshops for volunteers, explaining what are the hotlines available in Belarus. And the phone numbers also changed at that time. It was a challenge. We explained how to use the software and applications for online communication. We had to explain this, and it was a burning issue. We explained volunteers how to communicate over the phone, how to use other means of communication, and a lot of our clients were interviewed. We did polling survey on what are the communication means that they have. So before COVID and during COVID, we had a clear understanding safety is most important. Anything we suggest and offer to our clients, especially with cognitive impairments, priority number one is safety. Next criterion is satisfaction and comfort, because people with cognitive impairments have certain restrictions, and we got to learn that many people were staying home, and in majority of cases, and in best case scenario, they visited polyclinics and shops. And the last criterion is usefulness. The communication means. As for the pillars that we had, we tried to find out what are the personal approaches we can use and to ensure psychological welfare, to make sure that all the changes in our organization would be smooth. We tried to maintain the usual activities that we used to have and to maintain the independence of our clients and self-service. Our patronage workers never stopped their work. They were immediately provided with the personal protection means. We looked for ways to promptly interact with the doctors, and sometimes the patronage employees interacted with their relatives, because the people who had the official diagnosis, dementia or Alzheimer's disease, they could receive 168 hours per week. And this is almost 24/7. And another thing I would like to say is that we tried to use all the possible means of communication to maintain our club activities. And here I have to especially know that some people find it difficult to use gadgets, and we communicated with all the relatives, with all the staff members that ensure home-based visits. Sometimes it was neighbors or also the safety person in the building where the client lives. So we had lists of clients to keep in touch if we see that someone is not attending. The condition of our clients is quite difficult, quite complex, and before the pandemic, we followed up our clients. It was even prior to the COVID, and then during COVID, it became even more relevant. And if the class is on Monday, we called the client to remind that tomorrow you have your class. So some people use only landline phone. We use that. And we tried to maintain also the days of the classes to make it more comfortable for our clients. For us, it was a breakthrough to launch group work with family members on Zoom. We looked for different options. We worked on business days and days off, and we keep changing the time because during summer we released the day off and had the meeting on Monday. Then we rescheduled it to 5 o'clock on Mondays. And before we experienced big challenges, for now, the meeting takes place once or twice a month with at least 5 to 6 relatives. This group is joined and actively supported by our volunteers or people who have certain problems with their relatives and they would like to address those problems. And of course, awareness raising activities were continued. We currently cooperate with patronage workers and those individuals who work in our small groups. As an example, I would like to mention the following. On the one hand, we have contact with relatives. They are engaged more frequently and to bigger extent. A year ago, we tried to borrow notebooks. We had to keep in touch with the patronage workers, with relatives, to engage all of them, because there are some people who never used those gadgets and it's difficult for them to use those devices. On the other hand, the volunteers who were trained, they give calls to the clients from our groups on weekly basis, and they ask the clients how they feel. At the very beginning of the pandemic, there was a woman who was volunteer in the organization for a long time. Then she had a trauma, and we included this woman into the group with trauma or stroke. And one of the volunteers conducted a phone call, and he remembered that she was quite active, and he noticed that she became a person who talks very slowly. And he asked, how do you feel? She has a son and she never called the son. So our staff member immediately contacted the son, and he didn't pick up the phone, and we didn't see our clients for quite a long time. We had all the phone numbers that we could make a list, and we have the phone number of the security person sitting downstairs in her building, and we called her and said that we doubt that she's feeling well right now. We assume that the son is there in the apartment. So this woman came to this apartment to inquire about the condition of the woman, and in fact, it turned out that this woman had a stroke, and we managed to ensure timely medical care. There is another woman who lives in Belarus, and her relatives live abroad. However, her neighbors are quite active, and they moved away to another building. However, they still communicate with this woman and us to support this woman. There was a situation before the pandemic. During the class, we identified that we doubt whether she can see well, or maybe this is cognitive impairment. We called the neighbors. They took her to a doctor, and in fact, we detected an emergency situation. and her mood improved significantly. And in fact, she had deteriorated vision, and she saw a doctor for emergency treatment, and her mood improved significantly. So we engage people in patronage work, in person-to-person contact, and there are some clients who cannot work without the patronage experience. And the same is relevant for relatives. The situation that we face right now requires for readjustment. What I have mentioned right now is just maybe about 1% of our work. We will not hold offline activities for older person this year, but we try to resume the work of our clubs as much as possible during this year, and with the work of some online activities. Thank you very much for your presentation, for the practice you have shared. This is quite an interesting experience. I think it was like a lecture and recommendations. And thank you very much for specific examples that demonstrate how you work in practice, how you can engage local community. So we have completed our presentations. We can move on to our Q&A session. If you have any questions to our speakers, please ask them. And I have a question to Ekaterina. So in the past 10 years, the international policy with regards to rights and implementation of the rights of older persons with the community of people, with regards to community of people living with dementia. Based on your experience, Aneta and Ekaterina, can we say that the community, not talking about the family, but the community that is representing the immediate environment for the people, to what extent this immediate environment has changed throughout implementation of this concept? If this works out very slowly, what is your vision? What we as professionals can do in this sphere? So this is my question to Ekaterina and Aneta. Who comes first?
Ekaterina.
I would say this environment is changing very slowly. There was a time, there is a myth that any older person has their cognitive functions changing. It is not something which is related to their disease, but rather to older age. We had to work a lot on that. And I think that we have quite a big block of awareness raising for specialists. I'm not talking about the community in general. This was relevant for specialists even. If there is good attitude from the side of the immediate community, saying neighbors, the yard, the actual building of where the person lives, they understand, well, this person needs help. And when they understand the diagnosis, it's even better, because as of today, we are facing a situation that in our organization, we have a lot of older age persons, and they live alone because their children live abroad. That way, we had to find a solution, and volunteers could come and attend those people, provide home-based visits. And volunteers wanted to be active, they wanted to be engaged. So we mostly relied on the resources that we have internally. Thank you very much, Ekaterina. Aneta?
Yeah, I would agree with Ekaterina. I think the awareness among the national among the countries, in the countries, it's not still on the level that we want to be. The older people are not perceived like assets or contributors to the society. They are not used in the right way. As Ekaterina said, they are willing to contribute to the different sectors in the society, but we are not giving enough opportunities they to be involved and actively participate in every sphere of the society. And for example, in this finding, impact of COVID-19 on older people in South Caucasus, we saw that very little percentage of them knows about their rights, and they are not at all active or involved in decision-making process. Then the countries are implementing or developing some strategies, politics that are concerning older people, but they are not consulted in this process. So I think we should do more in this regard to raise awareness, sensibilization among the communities, and contribute to create this age-friendly environment, and also educate older people about their rights and their opportunities to be involved in the society more actively.
Thank you very much, Aneta. You highlighted the major focus, and I fully agree that participation of the community itself in discussion, not just providing some recommendation and policies, but participation in development of what is being adopted, because this is something that matters to those people. And thank you very much for highlighting this. Talking about the practices we have shared, we have a question to Aneta. What is the training that is provided to volunteers in Red Cross before they start working on the hotline? Because I understand they have quite a big scope of responsibilities as a volunteer.
Yes, thank you very much for this question. On these helplines or the hotlines, we had a different kind of profiles for volunteers. Mostly, majority of them were working previously with older people, and we providing them home-based care services. Also, they had education or training regarding the provision of psychological first aid and PSS training. Also, during this COVID-19 pandemic, because it was especially during the beginning of COVID-19 pandemic, when there were restrictions, the PSS Center developed online psychological first aid training course that is like on 1 hour. We had, for example, if the volunteers could not provide specific support to the older people, they would refer to the psychologist or some with more experience. But what is important, what I wanted to mention here is the trust the older people have towards Red Cross and Red Crescent volunteers. It's very important this trust to be gained at the beginning when you work with the older people, your approach and showing that you taking care about them. It's sometimes, you know, it's enough for them just to listen to them, what they will say. They want to speak with someone. And we have, maybe I will share with you also one information. Some of the national society have established this peer telephone support, like one older people is checking another older people, that the another older people is checking another. So we want to involve also older people in these activities, they to feel that they can contribute to this COVID-19 pandemic and be actively involved. And also, maybe I would mention in this the study that was conducted by British Red Cross, they had opened this also hotline. 75% of the callers that were contacting these volunteers had a feeling of anxiety and loneliness prior to contacting the services, but with support line helped them to reduce these feelings for 61% of callers, which show that that these tools or these activities really help to older people. And I also can share the links for this online PFA training. We have more specified PSS trainings, but I can maybe share my email and we can contact bilateral.
Thank you very much for your response and for additional information. And I am sure that this is quite interesting for practitioners, that there are certain results that demonstrate efficacy of working. And thank you very much for the links you have shared where we can look up the tools. And special thank you for being ready to share information. And I invite you, dear colleagues, to use this opportunity to keep in touch with Aneta if you have any specific questions. To continue the topic of volunteers, we have a question to Ekaterina. How do you organize enrollment of volunteers and search for volunteers to organize support to older persons with dementia? And how do you ensure the prevention of burnout? The way we started in 2016, we announced this internally in our organization that we have this opportunity to undergo training. We trained about 30 people and 18 stayed with us and only 15 were actively working with us. And these were mostly older persons. And based on our experience, the people who were prepared to support were the people who had problems with their relatives, parents, and people who died in difficult circumstances. Anyways, this is the readiness to see different situations. Yes, we did have certain enrollment selection. We tried to enroll everyone who wanted, and then we asked some particular persons to stay in this or that specific group, and we monitored how these people reacted, and we monitored their work. Of course, we do implement work on prevention of burnout. Before COVID, we were gathering our volunteers just once a month. We had two components to this meeting. First is to describe what are the challenges they came across in their work. And our employees said that maybe you have to recall what are the difficult situations they faced. And then it was, the second component was theoretical block. What are the actions to take in such situation? As for now, we have an extended meeting starting from June until now. This was stress management, panic attacks, and also the feeling of fear. And it's not only the older persons who experience such feelings, but also the volunteers. And we also hold meetings with our staff when they share with their supervisor what are the feelings that they experience, what are the challenges they faced in the work with the client. And sometimes this is conducted online through Zoom, because not always people can meet. So we try to adjust this to the technical aspects and to satisfy the emotional needs of the individuals. And there is a coincidence at the beginning of COVID. We used the Red Cross booklet, and for us, Aneta conducted the translation, so thank you very much for that. It was like emergency response. So we used this booklet to train our volunteers in Russian. So thank you very much for that. Thank you very much for your responses, and thank you very much for sharing your experience. And as we can see, Aneta, your experience is already being implemented in Belarus. This toolkit that you have developed. So
Yes.
thank you very much for your work and for what you do.
Thank you,
This
Ekaterina.
is appreciated. So, dear colleagues, I have another question to you. Taking care of an older person with cognitive disorders, this is a lot of effort for the family. This requires for awareness raising, certain knowledge, and it also depends on the emotional and physical readiness of the individual. So how do we identify who should help in that process? What are the organizations that should jump into this process? What should be done at the very beginning so that the family would not get, so to say, scared of the role that they have now and would not want to leave their close relative in a within the institution? Can I start? Yes. Ekaterina. Well, I was the relative who had to take care, and I would like to say a big thank you to my organization for helping me, because everything I was reading in the books I had to experience myself. And not only COVID, but also dementia before COVID. This is a big tragedy when a person is experiencing the post-COVID syndrome. They may be demonstrating some symptoms of dementia. Nevertheless, there are things that we have to explain to the relatives because the burden on providing care for this person may be taken up by some organization, but nobody can understand what it is like to be 24/7, to stay 24/7 with this person who is sick in your family, when you have to agree with your family members what time you go to the shop. So of course this is a matter of awareness raising and then acceptance. This is the most challenging factor, not to react, because you do have an expectation based on what this person used to be like, and this is the most complex work, to accept it. This is a matter of work during psychological meetings. We address this issue by inviting our colleagues who are professionals and relatives who used to live, whose mother or father used to have dementia. We had to ensure awareness raising about stroke, and we invited the woman who for 5 years was taking care of her mother after stroke. So I am talking about as a person who is living through this. And when you explain all of this, many questions just evaporate. But what is most in need is the care. If we look at the area-based centers, the care meaning that the person was brought some food and the person looks active, like as if they can do the rest themselves. So we should move away from care, saying just hygienic issues, and the person may look okay from the point of view of hygiene, but at the same time, this person may not be able to do a lot of things independently. So we need to look into this, how to do this officially, that the person would be able to receive 100 hours per week so that they can live their own life. Well, maybe 160 hours per week. And this would address a lot of problems. Thank you very much, Ekaterina. I think you have highlighted the major issues. This is support peer-to-peer, and also the possibilities to hand over some of the services that a family is providing. Going back to volunteering, we have a few questions to our speakers. One question to Ekaterina from Olga Lukashkova. What is the age group that usually demonstrates interest to join volunteer work? Is to provide care for older persons? Is this young people, middle-aged, or older persons? Well, we had different kind of work when we were doing broad awareness raising campaign to create this friendly environment. And we had this broad information campaign to invite people, and people of different age were coming, also school children and employees of different organizations and mature people. And these are the people who are prepared to listen. We could have generated volunteers of other ages, but we are facing COVID now. So usually these are people of older age because they have certain concerns. Well, this might happen to me, and I can provide the services and have an idea of how to keep engaged and active. And also this may be mature people, middle-aged group. Usually this is work, but if they got to see certain challenges with their relatives and they have an understanding of what it may be like, and if the parents passed away at their early age, they usually engage to provide care to as if their mother or grandmother that they are grateful to. Youth, no. But they did help us when we had to do delivery, but not this kind of direct support when they would have to stay at home to accompany to the toilet or etc. It's more difficult. Thank you very much for your responses. So it's mostly the people who are affected. As for volunteer work, we have a question to Aneta. Question from Anna Sidarenko. Is there in Red Cross a system for motivating volunteers, and how this system is implemented?
Thank you very much for this question. So the volunteers that are coming in the Red Cross, they are motivating by their own needs, and they want to help and provide support to different aspects or activities that Red Cross national societies are implementing. So the national society have established different kinds of motivation system for the volunteers, but what is mostly important is to show respect to volunteers for their engagement, to recognize their achievement, to build this team spirit, to work with their peers, and for them sometimes it's just enough to be with their friends, to help each other, to help and involve, for example, in some disaster preparedness, for example, activity or home-based activities. So based on their needs and the personal choices, we are involving them in implementation of different kind of activities. So it's personal choice in which activities they would like to be involved. And also what we want, what we put attention is on their encouraging their development and training skills. So based on their preferences, they can develop not just in this topic that they have chosen, but in other also topics. So many of the volunteers are starting in the most of the national societies with first aid, and then slowly they are engaging in other activities. But it's very important to show respect, as I said, to them, to meet also their basic needs, and to open the door for big opportunities. Also, some of the national society have established awarding system. So many of them, they received some awards, for example, for their engagement in the Red Cross National Society. But mostly, like I said at the beginning, it's their own willing to help somebody and to contribute to the society. So for them, this is the motivation to feel that they helped somebody, they put smile on somebody's face. So yeah, it's you need to feel it and to see it. But yeah, thank you.
Thank you very much, Aneta. You have mentioned the system itself, because it is a system, the understanding of the feeling of belonging to some community. It is important for a person to see the final results of their work, not just participate and get to see whether something has changed in the life of a person. I think it is very well elaborated. And those motivational support, motivation groups, I think it is a well elaborated system that is operating successfully. Well, it looks like we are winding up our organization. However, I would like to ask a question to Ekaterina. You mentioned the challenges that you come across in your work, and one of the challenges that you have mentioned is lack of awareness among relatives, specialists. So my question is, what is this related to? We are facing vast development of technologies, a lot of information available, and dementia as a scientific field is developing quite swiftly. So what can we do in this context? Even the doctors say that it is very difficult to set the diagnosis. This is with regards to specialists. If we talk about dementia when it is the last stages, it is all very evident, and there is a big gap in the middle. It is a desert when the person is externally active, but internally they are immense processes inside. And the majority of specialists, when they came for internship, we had the possibility to invite people from different regions to see how the work is conducted in the group. The first phrases that we heard, especially if they were never working in the complex groups, difficult groups. And there was this like a mix. And they said, oh my God, are they all normal? So this is the perception, this is the myth that if the person has dementia, this person should be not looking very neat, not be able to talk, and etc. So the question is, what do we do with the people who look fine, respond to questions, remember everything about their childhood and the war? They just start confusing the day or forgot to eat yesterday. So gradually, we are filling in this gap. There are some questions of this kind of sensitive nature, meaning requiring for in-depth vision, should not always be covered. But we had a period In 2013, dementia was and throughout this period, in every region, we were trying to do it all. So when the organization will have to create daycare for people with cognitive impairments, and it would not be a prevention group who are fine for now, and people who need care because they can't do something themselves. This is the group of people who are to be active and need to maintain their activeness. And the specialists would have a better vision. But for now, what do we offer them? So this is the group when it's that comes into our vision when it's burning. So we need to identify what are the needs. Thank you very much, Ekaterina. I agree that this is a matter of correct information. And we do not have this clear separation, clear vision that this is the light form of dementia, but it does require for certain effort. And for now, we can see that this is all based on stigma that exists in our society related to dementia. I was talking to psychiatrists, and they say there is this MSA where the maximum number is 30. If the person is 22, this is the initial stages of dementia. When we talk to the doctors, no, we would be setting dementia when the indicator is 18. Yes, at this stage you can see a lot of things. It's not only the doctor who can see it, but also the neighbors. I'm not talking about the family members. And my question is, what is it before that indicator of 18? Yes, early detection is very important, and there is vast experience in different countries in the sphere of healthcare and social services. When we do not adopt any activities, it would cost us. It would cost us a lot when this person would have a deteriorated condition. Our colleague tried to calculate how much it costs to engage volunteer, to cover the cost of our employees, delivery of foods, and etc. It is about 45 euro per person. That's quite a lot of cost for the system and the society in general. We should be starting to understand this together. I express my sincere gratitude to our panelists for your wonderful experience, for sharing your practices. I'm sure it would be useful for our participants. And I thank our participants for asking questions actively. We will have a break until 12:45 Minsk time. You can move around a bit, get a cup of tea, and stay with us. So we meet back here in 20 minutes. Welcome back, dear colleagues, to the main room of the Silver Forum. We reduced the break a little bit. I was working in the communication parallel session. There was quite vivid discussion there, and I hope my language is easy to understand enough, and I will try to use this knowledge in the future. The session was very useful. So this is the final panel for today, opened by Ms. Taisiya Eletskikh. Taisiya is the Business Partnership and Social Entrepreneurship Specialist in the UNFPA office in Belarus. She was at the grassroots of the Global Compact initiative in Belarus, and she will take the floor now. Taisiya, over to you. Thank you very much. Let me open my presentation. Can you see it? Yes, we can see you and your presentation and this window. If you press Control L, yes, this is PDF. It should work out if you press Control L. F11, please try F11. It doesn't work out. So to the left, press the preview. Is it fine now? Let's continue this way so that we don't waste our time. Good day, dear friends. It is my big pleasure to introduce our project of the UNFPA and mobile operator A1. Let me start by saying that all the goals in business and state sector can be achieved without solidarity and mutual partnership. What I will introduce today is the example of how the effort implemented jointly can address the problems of the society. We will be discussing the topic of digital literacy among people of older age. Previous speakers explained a lot about improving digital literacy among people of older age. This helps older persons to lead active life. Mobile phones, smartphones, and tablets have a big capacity in the sphere of improving confidence of older persons in integration, socialization, reducing social isolation, and etc. It is especially important within the context of coronavirus and development of the innovation approaches in providing social services to population, where social skills and digital skills are quite important. At the same time, this is training activity for the brain. It is important for prevent cognitive impairments. We remember, feel, imagine, and develop our brain activity through the neuron connections, neuroplasticity. If we don't train the brain becomes more rigid, and this may lead to serious consequences, including mental disorders. This is also confirmed by scientists. According to Cambridge, scientists, additional education reduces the risk of dementia by 11%. Training brain activity stimulates neuroplasticity and is one of the ways to ensure neuroplasticity because it keeps brain active and helps preserve clear work of brain. So the contribution of digital literacy into social welfare of older persons, it should not be underestimated. So let us look into a few facts about people of retirement age on the internet. We need to note that Belarus is the country of older persons. 1/4 of the population is pensionings. It is difficult to imagine that during the age of digital economy, only out of 2.5 million, only 41% uses digital equipment. This is quite low rate. These are the people at the age of 45 to 65, and these people are likely to follow the progress. As for the people at the age of 65 years old and over, usually don't use internet or use it to limited extent. we need to note the interest of older persons to engage in the use of internet. So we can see the statistics here. In 2010, the statistics was 2% of among the older persons who used internet. Now we can see that it's about 41%. 34% of internet users among older age persons live in the capital or in larger towns or cities. As for rural areas, these are only 22%. Over 82% of people at the age of 75 years old and over have never used internet. So to sum it up, we can say that older persons at the age of retirement, about 65% do not know how to use internet, and COVID has a detrimental impact on that. And of course, as compared to pensioners and people of retirement age in European countries and the US, Belarusian people are not that much engaged in the progress of digitalization. As I have mentioned, it is difficult to address different objectives and UNFPA is actively working in this field, improving the quality of life of people of older age, developing new opportunities for social and economic activities, and improving their digital literacy is very important for those people. And the mobile operator A1 understand this very well. And improving digital literacy for older persons is quite important, and A1 company mobile operator supported us. It is a member to A1 Telecom Group with a corporate social responsibility strategy. So we united our efforts to implement this project. The goal of the project is to improve the quality of life of older persons and to develop new opportunities for enhancing their social activities. The target group is older persons living in Minsk and in the country in general. The mobile operator did not have sufficient knowledge on how to work with older persons, which is quite important for the success of the project. What we did is we provided the dialogue platform, our expert support, and in general, the success. Our project was destined to be successful. So there are three key components to our project. First of all is development and dissemination of the guidelines for older persons, development of digital volunteer movement. This is enhancing and capacity building for activities for volunteers working with older persons. We started off with a press conference with the festive event on signing our partnership agreement. So what are our achievements throughout these 5 months? Well, first of all, we developed the toolkit for training the guidelines to the world of digital technologies, expanding volunteer network, training for social workers, volunteers. What are the characteristic aspects? How do you train older persons? Cooperation started off from these guidelines and mobile technologies. What are the aspects of it? First of all, it is developed specifically for the client. Before publicating it, we worked with the organizations working with older persons. We tested the content, whether it is user-friendly for older persons and whether the content is clear. We published 20,000 copies. 8,000 copies were distributed between 150 area-based centers for social services working with older persons. As for the rest, these are widely available in shops, free of charge. The clients may obtain it free of charge. There is an electronic version widely available to general public. I will drop a link to the chat. And you can download this guidelines, and also I apologize for interrupting you. I would like to invite you to fit into the 5 minutes. I know you have quite a lot of information. So going back to the volunteer network, the digital volunteer movement started about 1 year ago. So there is quite a big increase in the number of volunteers in the past 5 months. We have 655 people of older age trained as of today. There is a Telegram channel where people can exchange their success stories. There was a contest on the results of training volunteers and social workers. It is important that we have trained volunteers and social workers. We conducted seminars in all the regions of the country where our experts trained on how to work with older persons, what are the theoretical aspects, and the easy to read language that is necessary for training. And over 600 persons improved their competencies in the sphere of digital literacy. Here you can see the step-by-step instruction. So what are the perspectives that we have? Well, first of all, we need to expand volunteer movement with volunteers of the Red Cross and etc. so that volunteers increase in number. However, there is a need for guidelines for social workers in order to build the competencies on how to use tablets and smartphones to train all the persons. So here are the major perspectives, and there are a lot of benefits for improving sustainable development, to ensure sustainable development, to reduce digital inequality, to enhance access, and work with the consequences of the social isolation due to COVID, and for people who have strong command of digital literacy. And also, this demonstrates corporate social responsibility of the company. And there is no better way to achieve the results than achieving the result together by joining effort. This is the way to achieve our goal together. Thank you very much for your kind attention. We will demonstrate a short video.
В июне 2021 года движение «Я онлайн» расширяет свои границы. Для начинающих пользователей мобильного интернета А1 и фонд ООН в области народонаселения в Беларуси выпустили специальный «Я онлайн-путеводитель» по миру современных технологий.
Thank you very much for your kind attention. I would be pleased to respond to your questions, if any. Thank you very much, Taisiya. That's a cute video and nice presentation. The next speaker is Zeljko Blagojevic, Assistant Representative at the Interim Program Analyst, Population and Development Strategies, Monitoring and Evaluation, Office of the UNFPA, initiator of a number of activities in this field of aging, and the research introduced by Trgachevska. This is in many ways interrelated, and I'm pleased to pass on the floor to Zeljko Blagojevic.
Thank you so much, Philip. Dobry den and good afternoon to all the participants. I'm going to talk today about healthy aging centers in Bosnia and Herzegovina. I would say a sort of a revolutionary methodology that we, I would also say, accidentally developed some 10 years ago in cooperation between UNFPA and the local and partnership with local NGO Partnership for Public Health. A network of healthy aging centers was developed across the country, and at the moment there are about 17 of these centers across 9 municipalities in Bosnia and Herzegovina, attracting altogether several thousands of older persons. What are actually healthy aging centers? Those are day centers for people where they come every work day to spend time with their peers, to engage in different activities, and also to exercise on a daily basis. And this exercise is very, very important from the perspective of maintaining not only physical health, but also mental health, as many older people, and I'm sure that's also the case in Belarus, are home alone for most of the time every day. And this especially is important for female population, as women live longer than men, and eventually when children leave households, they stay alone without any or with very, very little support, especially when it comes to public services. In the other words, it's very important, to provide or to organize some sort of facilities for self-help, where people could not only participate in activities, but actually contribute and attract other older persons from local communities to join the centers, work with them, and directly support them. The centers currently provide several types of activities. Some of them are as simple as, having some morning routine, spending time with your peers, drinking tea or coffee and reading newspapers, so enabling socialization between people. But on the other hand, there are different activities like art courses or music courses, etc., where people could actually actively engage in different activities. And of course, there is this separate session or separate exercise terms where people come every morning, and there are several groups in each center where they exercise for at least half an hour. Exercises, as I said, is very, very important, and in order to provide support to those people, especially during the COVID pandemic, we actually cooperated with a national TV broadcaster to record a series of videos of older people, actually instructors providing instructions to older persons on how to exercise without putting too much strain on their health. But at the same time, all these exercises are adjusted to the needs and capacities of older persons. I'm not sure if it's okay. I would share the screen briefly just to show you how all this looks like. Is this one? Okay, I hope you can see it. This is. It's easier to show it on the Facebook site of UNFPA, and these are 5 exercises. So one for every work day in a week that were developed, and these exercises are some 10 to 15 minutes, so they're very much adjusted to broadcasting on TV. And as I said, we closely cooperated with the national broadcaster to show this for a while, so that people, while they were locked at home during the pandemic, they could actually exercise and in that way preserve their physical and mental health. I will just let one of these run so that you can see how it looks like. So just for you to see, all the exercises are guided by the instructors, and actually it's the older persons members of these healthy aging centers are participating in this and showing the exercises that they practice actually every day. I will stop here with sharing. This was just to show you how it looks like. In the next step, what we did is that actually we use the Viber phone application to actually, we developed a Viber bot that serves as a platform actually for people who may not be, I don't know, who are not very skilled to use certain online platforms like Facebook or something like that. And in Bosnia and Herzegovina, many people use Viber for communication, especially those who have children and family living abroad. So we developed this Viber bot. I cannot unfortunately show you it here, but it's very simple that when you open the Viber and type starenje in local language, that it actually shows you the link, and it's very, very easy for people to follow up on the link and actually get access to all these 5 exercises. So the good thing is that it doesn't matter where you are. It doesn't matter if there is a lockdown or something like that. People could easily, they do not even have to go to healthy aging centers to be members, because healthy aging centers, of course, cover only some local population living around those centers. But for many other people across the country, when we broadcasted through national TV broadcaster and when we published it through this Viber bot, actually it gives opportunity to many people, especially those living in rural areas, for as long as they have internet access, to actually live actively and healthy aging. I will stop here. I'm not sure if I spoke for too long or something like that. Maybe it's better, and I really prefer to have some questions or comments from the audience. Thank you.
Thank you. We have plenty of time, in fact. That's why. No big deal. I regret to inform that Ms. Anna Morgan will not be able to join us today, which means we head straight to our Q&A. I see a question for Mr. Zeljko Blagojevic.
I can.
Yet let me read this. This is from World Jewish Relief.
Yeah, I can see the question. Well, actually, what we have done is that UNFPA a couple of years ago cooperated with the University College London with Professor Tara Keck, and we conducted a survey in 2 healthy aging centers. And actually, what we tried is to understand the effects of healthy aging centers to the health of especially mental health of older persons. So there is a report on our website. So if you go to ba.unfpa.org, and among the publications, you will find the report that was actually published last year in the middle of the COVID pandemic. And you will see that actually people coming to the centers are having a bit more advanced health condition. So, there was another survey conducted some 5 years ago, only in that first and major healthy aging center in Sarajevo, and it was also the survey had shown that the benefits of healthy aging centers are many, and that many people even stop using their prescribed medications all the time because their situation significantly improves. So both of these reports you can find at our website, and we have done another survey, although not in healthy aging centers, but across 6 countries in our region, Eastern Europe and Central Asia, on loneliness in older persons. As our initial survey had shown that even people who come to the centers, they still state that they are significant, that they have this feeling of significant loneliness. And although there was some reduction in comparison to population that is not coming to the centers, the loneliness is still widely spread, and there are many steps that need to be taken in each country actually to further reduce the feeling of loneliness. This report is, the third one is finalized just now, and we are planning for the end of January to have a regional presentation. So I would very much welcome you to join us. I think it will be last Friday in January, and I believe that each country office will actually extend invitations to all their partners and stakeholders to join us and to listen more actually on these findings. Thank you.
Thank you. I have a question. We have a question for Taisiya. 2, to be more exact. First question to Taisiya is from me. So the older groups participating in the project, are they made up of people who are already involved in the project and you need to improve their literacy, or is it about newcomers, those who have no familiarity with the internet? Our task is to give digital skills to those who had no familiarity with the internet, and of course to build capacity and literacy of those who have basic skills. But our job was to train the trainers who would go on to train the others, or the volunteers, so that they are tactful, they are aware of some specifics of building a message to senior citizens. That was our focus. In the meantime, volunteers do what they're supposed to do, passing the knowledge to their grandparents or parents. Social workers would train those under their care. So that was our main goal, to introduce our expertise in the training process and to step up to elevate level of literacy among 65 plus. Any critique, any feedback, do you measure efficacy? I did not have time, Of course, we covered 650 people. We trained them, 650 senior citizens. Then 3,695 people thanked us in writing on the website. Our guides are in huge demand. We had only 20, even though we had 20,000 copies, they were distributed like hot cakes. The program involves volunteers by motivating them, by giving some free traffic to use for training older people. So feel free to join if you have a chance. You can join us through our website online. I want to thank Zeljko Blagojevic and Taisiya Eletskikh for their wonderful talks. So with this, we are headed to the final part of our workshop. We will try to recap what happened. So I want to bring up once again moderators of today's parallel sessions, Alena Stanislavchik and Mr. Sergei Kruchinin, to recapitulate what happened. 5 minutes each. If you can make it under 5 minutes, that will be great. Alena, would you like to go first? Sure. Thank you, Philip. Our today's section was dedicated to community engagement. So participants representing prominent organizations shared their practical cases and experience with us, and those are just great and can be used by all the other participants. The key takeaway is that communities are a tremendous resource that we need to work through via education, enlightenment. Unfortunately, the process is not going as actively as it could. And when it comes to severe cognitive dysfunctions, it's a bit more challenging to work with. At any rate, what we heard today was the contribution of volunteers cannot be overestimated. And those organizations that shared their knowledge, and there are dedicated studies measuring the efficacy, is enormous. One of the gaps we need to fill is lack of awareness in the general community and among professionals, especially when it comes to early detection of dementia, when you need to take action at very early stages. Unfortunately, until a person falls in tighter focus of the government or social services, the only support for that individual is local community. And if you do not engage that individual early on, then we have someone with advanced stages of dementia, which could have been averted. Summing up, we covered a lot of topics, like, for example, a lack of services, a lack of support for caregivers. We're in the early stages of this path, but awareness is a great way forward. And as professionals, we can do a lot of things in this area. Thank you. Elena, Sergey, let's have your recap. I'm thankful to the forum, and I am thankful for the opportunity to moderate this communication panel. I'm grateful because I met or re-met excellent people who contribute significantly in this activity. The topic of easy to read language, plain language, is called for and relevant not only for the elderly, but for the entire society in general. Alexander Shotkina, on the other hand, representing Russia, specializing on Alzheimer and people suffering from it, provided insights into communications and communication campaigns and shed light on how they overcame various barriers, talking to the press, mass media. Once those barriers are negotiated, those mass media line up to cooperate with her, to interview her, or to get some information from her. Marita Guerin from Germany made a splendid presentation. She was representing effectively the municipality of her town. We may only start to institutionalize in their town. It's an established fact, and it's a point of reference, something to aspire to. Of course, they do have challenges they need to tackle. The only regret I have is that the session went by so quickly, and we wanted to cover a lot more ground, which tells you that we need to explore further. We need to have more subject matter discussion on this topic. Thank you. Agree completely. Still things to discuss and still things to do. And our today's forum will give us clear indication of where to go. I'd like to bring up Olga Atroshenko for the final presentation.
Thank you very much, Philip, and many thanks to the colleagues who have been with us, who shared their thoughts with us, the ideas as panelists, and the people who are very much interested in this field. They are asking questions, they're interested in what is going on in other countries. And let me repeat once again what I mentioned yesterday. We have very vast geography. We had Finland, Israel, Copenhagen, to Novosibirsk, and today we were joined by Bosnia and Herzegovina, Germany, speakers from the UK. And again, yes, we are facing the same problems. It is important to find solutions to these problems, ways to address them. And yesterday and today, we kept saying that there is a number of directions and factors that may facilitate achievement of the goals for the benefit of the welfare of people of older age. And those factors include practical tools, data collection, IT technologies, correct communication, easy to read language, with no stigma. Interagency cooperation, which is something we discussed for a long time yesterday and today, and use of IT technologies. However, all of we can be successful when we combine it all together and when we work in this field all together professionally with those professionals and specialists who were represented here during the forum yesterday and today. Those 2 wonderful days of the Silver Forum open our eyes not only to us and myself as a person working in the UNFPA, but also as a human being, because we don't always pay attention to all the things and aspects during our daily life. And sometimes when we're convinced that we're doing right, we are doing it the wrong way. However, now we are well equipped with the information, which is an important component to our life. And to wrap it up, I would like to say that these 2 days went very smoothly. And this is our step forward. The first Silver Forum that we held on the issues of older persons and the issues of mental health and welfare, we shall continue. We are planning. At the moment, I cannot say the time frames, but I am sure we will hold another forum, and not one forum, a few forums. And as feedback, I would like to highlight the topics that would be important and useful with regards to older persons that we could discuss during the next forum jointly with the experts that will be working with us from different countries and from Belarus. And a big thank you to the moderator, our co-moderators, moderator Philipp, Anastasia and Vitaly, the interpreters, our technical team, and to all the speakers and panelists. I'm prepared to list you all, but it would take some time. A big thank you from all the heart, and I'm passing on the floor to Philipp. Philipp, over to you. Olga, thank you very much. This is very much appreciated. Let me express gratitude for inviting me to moderate. For me, this is a very interesting experience. The forum turned out to be very useful for myself. All the speeches are now building one single canvas. We used to discuss the problems on the level of theory. We discussed ageism, social isolation. Then we were looking into the practical aspects, what social isolation leads to, some dementia conditions, some cognitive impairments. Then we moved on to how do we counteract social isolation. And we discussed the experience of volunteer organizations. How do we establish communication with people of Silver Age during the time when we cannot approach them close enough physically, and we need to use digital technologies. What are these technologies that we can use? There are some software IT applications, some mechanical items that can simplify the life of the older group. And we can put down all the recommendations and implement the guidelines. And we have touched upon the issues of the language, and this can be all stipulated in a general strategy for future development. And I am fully sincere when I say that this forum benefited all the participants. And what has been mentioned here, we can start implementing. It is important because there are quite a lot of problems, and it is time to address them. It's time to move forward and address the problems. we should stop listing them and start addressing the problems. It is important for people of older age. Before we say goodbye, there is an important aspect. We kindly ask you to fill in the feedback form. My colleagues just popped the form into the chat. There is the English version and the Russian version. Please fill out the feedback form. And let me thank once again the organizers of the forum, UNFPA, the people related to UNFPA. And Olga rightly mentioned that we should mention one more person personally, Maria Duvakina, because Maria organized it all. Yulia, our communication specialist, has put a lot of effort. And Masha was not sleeping at night. She was working all the time. Masha and Yulia facilitated the participants, and that's a lot of work. IBB, I won't mention the full name. This is the federal, the program of the federal government of Germany, providing support to this project. It was a big pleasure to moderate this forum. I wish you all the best. I wish you good continuation of the day, and a big thank you for being with us. Thank you very much.